Going down to the neoplastic conditions. All the neoplastic conditions are responsible for hyperthyroidism. Okay. So after finishing that, we will go to hypo, which has got two conditions. So what are the features which favors like neoplasia in case of in a person? Like all of us are there, we might be prone to having thyroid carcinoma. So what are the things? So usually it is a young age. If you are having a thyroid swelling, if a patient comes to you with a thyroid swelling, you are seeing that the patient is young, and there is only solitary one swelling, because just now I told you multinodular goiter will have multiple presentation. Like when you palpate here, you will have multiple nodules, so that's a sign of benignity. But when you get a single solitary swelling, and sometimes what we usually get is like we don't have a thyroid gland to palpate. There is a lymph node swelling in the axilla or the cervical group, and we are doing some sampling over there, and we are getting carcinoma there. The thyroid gland is absolutely normal. This is the usual presentation of papillary carcinoma of thyroid, okay? And very, very young age, like 30s and 40s. So this is one thing. And as I told you, every disorder is in female. So when a male is presenting with a single solitary thyroid nodule, the chances of malignancy is more, okay? Then if there is any history of radiation, like anybody who is a radiologist or working in a radiation factory, so that will cause. And as I told you, cold nodules, like the uptake is less. Fine. So the first topic in no talking. You're sleepy, you can go to sleep. Now why do you want to talk? No, I'm not objecting if you want to sleep. You also, these continuous people who are talking. You can give your attendance and leave also. You can do that. Like it's fine with me. You can give and go. You want to give? I'm telling you, you can give and go. I don't mind it, but I don't like you talking there. Fine. So I was just talking about adenoma. So this is the first step in the neoplastic disorders. This is the benign one. Okay. Adenomas are always benign. Wherever it is present, just remember it like that. Adenoma always means a solitary nodule which is well encapsulated. Okay. Like it has got a capsule which is keeping it intact and inside. It is not letting it invade anywhere. So that's why it is very, very benign. Adenomas are always benign. So here the question for you, adenomas usually don't come. The reason for teaching this is because there is a follicular neoplasm which you have to know, and follicular neoplasm and follicular adenoma are always very tricky with each other. Okay, so the diagnosis is tricky. So that's why I've just put up these genetic mutations and all you don't need. I'm not putting them. So all I want you to know from this slide is that it is unilateral. It will be single solitary nodule. Usually the presentation is painless. All malignancies are normally painless. There is one painful one. I'll tell you when we go to it. The size can be very big, can be very small as well. So this is the presentation of adenoma. Just know that. This is how it looks. If you can see, it looks very nicely, neatly encapsulated. There is this. If you can make out this area, this is the capsule. Okay, and it is not invaded out of the capsule. So this is what it looks like. And when you take a histology, this is the capsule here. This is the capsule here. And this is the normal thyroid which has got compressed because of the expansion of the lesion. Fine. And this is all chota follicles here. Small follicles will be present. Fine. So this is just the basic understanding. Just understand adenoma is well encapsulated. It is not breaching the capsule. It is inside. It just compresses the normal thyroid. That's all I want you to know from this. Usually it's not a question. It's the same image. So now we move on to the malignancy part. And in this you have to know three malignancies. One is papillary carcinoma of thyroid, one is follicular carcinoma, and one is the medullary carcinoma. Three of them only. Don't read others. It's not required. So papillary carcinoma thyroid is very easy to remember. Very simple. One of the most common carcinomas of thyroid and very, very frequently seen. Anytime. Like in a month you at least 3, 4, 5 depending on the intake. So as you can see, it makes 85% of the thyroid carcinoma. Age will be younger, 25, can go up to 50 years of age. Usually, as I was telling you, the presentation is cervical lymph node. It will come as a lymphadenopathy and the thyroid will be normal. The prognosis of almost all thyroid carcinomas are excellent. So if you have diagnosed it well, it is removed, it's fine. Okay. Then next we'll go on to this. So you can see just now I showed you an adenoma, and you are seeing now a carcinoma. How different it is. There is no demarcation. Much of demarcation is not produced. Some pseudocapsule is present here, and the lesion is grayish white to grayish yellow. This is what is grossly it appears. Okay. Now you take a sample from here, and this is what you see. Lots of papillae with fibrovascular core. You're supposed to write that in your answer sheets. lots of papillary infoldings with fibrovascular core. And what do the individual cells look like? The individual cells look like what is known as orphan ani. Okay, basically they have empty or optically clear nucleus. The follicular cells which you had seen them were cuboidal, now they are looking optically clear. Okay, so look at the variation you can see in any disorder. They barely have left of colloid, very less colloid if present, and they are all in papillary infoldings. Fine. And they show some amount of calcifications, that is known as samoma body, that also you are supposed to mention. Okay, so these are nothing but these are the calcifications here, samoma bodies, and these are some of the colloid which is left out. This empty regions what you are seeing, this is known as scalloping. Scalloping is eating away. So you can mention this here as well in the histopathology, that scalloping of colloid is seen. Okay. So what are the things you are going to write in papillary carcinoma of thyroid? First of all, you write about the age and all the clinical aspect, whatever is there. Then secondly, you write that it is like grossly it is pseudocapsule might be there, it might be encapsulated, and it is greyish white to greyish yellow. And then you write the histopathology, where you write lot of papillary folds are there with fibrovascular core. The follicular cells now become optically clear. Colloid may or may not be there. If there, they show scalloping. Okay, this is basic for you. You just mention this. We know that you have read your subject. Okay. This is just an example of microcarcinoma. I was just, out of curiosity, I have put it. Like I was telling you that thyroid might be absolutely normal, and you have found out the carcinoma is metastasizing to the lymph node. So when you take the thyroid out, you will just, this is looking big on a slide. If you see, the thyroid will be absolutely normal. Everything has been extracted out and nothing will be there. And when you give, then only microscopically you are seeing this much fragment showing this carcinoma. Okay. Now next we move on to the follicular carcinoma. Malignancies are easy. Okay, there are not much pathogenesis. You just write some genetics and you are done. The difficult part is the benign part. You have to understand what is Graves, what is Hashimoto's. Just you have to be very picture clear about it. Fine. So follicular carcinoma, no talking. You two can just go, if you have to talk, please go. You just give your attendance and go, then I'll continue the class. Chalo, get up and go. Both of you at the side, please get up and go. You're continuously talking from half an hour. Please just go. Dr. Ashish, please take their attendance, those two. You two only, what is this row? Second row, please, just go. You can discuss whatever you're discussing outside. You are discussing from that time. You two there and these two here. At the end. I don't know what they are laughing about from that time. What is so funny? You four only. Four of you just give and go, yaar. Just go. Go. Give and go. There is no harm. I'm not going to cut your attendance. Just give the attendance and go. You two also. Both of you. Chalo. There is nothing to be slow motion. Give and go. Fine. Okay, so follicular carcinoma. So this one is like, the second most common of all the thyroid carcinomas. And why important? Because this is, like the prognosis is good, but it invades very quickly. Okay, the invasion is very fast, it spreads to the nearby organs. So you have to differentiate between the adenoma and the carcinoma. So that's why for you it is important to study. So the age of presentation is bit elder compared to the papillary thyroid carcinoma. It is 40 to 60 or can go up to 45 to 70 like that around. And this is again painless enlargement, and this dietary deficient areas, these are all not much required. The thing which is important is grossly it is infiltrative. It can have a capsule, but it will be infiltrative. So the only thing which helps you understand or makes you know that how, if it is a malignancy or if it is not, is you have to look for two features that I'll be showing you shortly. So first let's see how the follicles are looking. The normal thyroid follicles, which are the small ones, that will only overgrow. There are no big follicles here. There will be small follicles which have overgrown. So they are usually microfollicular. Okay, if you don't write the term, it's okay. Just write there are a lot of small follicles present. Okay, some amount of colloid will be there. Here the colloid is not exhausting completely like that of the papillary carcinoma. Fine. Now the feature which I was telling you, you have to identify two features to tell it malignancy. First one is the capsule. The capsule has to be invaded. So it is known as capsular invasion. So this is the entire capsule, fibrocollagenous tissue if you can see, and this is the tumor bud which is infiltrating into it. Okay. So that is how you differentiate between the adenoma and the carcinoma, and you have to mention this point if it is asked in your question. Follicular carcinoma has come. Do not forget to mention about capsular and vascular invasion. Okay. And this one is a vascular invasion. So this entire thing is a blood vessel. Okay, this entire thing, this part. Fine. This is lined by endothelial cells. These small blue cells, these are the endothelial cells. Okay. This side, even they have destroyed the blood vessel. Half of it is destroyed by the tumor cells, and these are the follicular cells in between. You can see here also another blood vessel is there. It is filled with RBCs. So similar thing, these RBCs. These are all pink things are RBCs. Okay. So that's how you identify a blood vessel. It will be lined by endothelial cells. There will be RBCs inside it, and these are the tumor cells. So when you are writing follicular carcinoma, write about the age and all those things. Then write grossly it is infiltrative, might be encapsulated, and in the histopathology there will be overgrowth or hyperplasia of small follicles. Some amount of colloid will be preserved, and to tell it as neoplasm or malignancy, we have two things to see: capsular and vascular invasion. That completes your answer. Okay. Prognosis wise, it is good. It's not like if you have eliminated and it's bad, but the thing is it spreads very fastly. Okay, that's all. So this is another example of capsular invasion. This side the entire carcinoma is there. This is the capsule, and it has gone beyond the capsule. Okay. So you can just imagine, you will tell me that there is no other organ beyond thyroid, so how does it matter even if there is a capsular invasion? But it's not like that. It goes to the nearby organs. Okay. Fine. This anaplastic is not required. You don't have to know. You have to know medullary carcinoma. So this is the third of the category. Remember when I showed you the histopathology, I showed you something called as C cells. I was telling it's a neuroendocrine cell. Okay. So this is the malignancy of the neuroendocrine cells. It's known as the malignancy of the C cells only. So there are very few. They might be like in one, like one side, the right side upper lobe, there might be, you can say, some 10 to 15 C cells and so many thyroid follicular cells. But those 10 to 15 cells can go for malignancy. And neuroendocrine is present entirely in your body, all over your body. They have those similar functions, but their malignancy is very, very uncommon, and if it is there, you have to treat it. That's the problem. Okay. So you have to find out. To find out the diagnosis is actually very rare, but it happens. Fine. So it's a malignancy of the C cells. Age group is similar to follicular, older age group, not in the younger one like PTC. What is exactly happening here is, you have to just remember this one, that whenever this malignancy is there, some hormones are getting raised. There the thyroid hormones were getting raised. The C cells do not produce the thyroid hormones. They produce something known as calcitonin. So here the calcitonin is getting raised. Apart from that, ACTH and VIP, anyone with the full form? Okay, vasoactive is also one. Yes, okay, fine. So that one is getting raised. ACTH is getting raised. So what I mean to say is, these are all productions of various neuroendocrine cells. So when something is getting activated in the thyroid, also the other ones which are present in the gastric area, present in the kidney, they are also getting activated, and they are producing the same things. Okay. So the entire neuroendocrine system might be activated. Okay. So you have to write in medullary carcinoma. Remember, it is medullary carcinoma MC. So medullary and calcitonin MC. You can just make an abbreviation like that. And also the genetic mutation, RET PTC, you have to write that. You should remember it. Okay, without fail, you have to write this. The thing with this is not a good malignancy. It has a bad prognosis or a poor prognosis. One more thing to be remembered, because when you are giving your, if you are going to give your NEET, SS or super specialty exams, this will be a question. It is something known as MEN syndrome, MEN, multiple endocrine neoplasia. So these, like MEN has got a lot of category 1 and 2. In 2 also we have a 2A, and 1 has 1A and 1B. So in that, medullary carcinoma is one which is very common in MEN syndrome 1 type. So you should know that. Fine. Now how do they look grossly? So grossly they can be unilateral, they can be bilateral. This can present just as a solitary nodule, this can present as multiple nodule. This can be just present at one location known as unicentric. This can be present at multiple locations like multicentric. So the presentation is very varied. Okay, medullary carcinoma, remember, one is calcitonin, one is the presentation is very varied. It can grossly be anywhere like in any shape or any format. Solitary, multiple, unicentric, multicentric, unilateral, bilateral. Anything can happen. Okay. And usually it is grayish white because of the calcitonin C cells. Now how does it look on low power? There will be proliferation of C cells, so everything, there will be not like follicles. No follicles will be there, nothing such. There will be very tiny cells entirely filling up the thyroid parenchyma. Whatever is left, there will be small cells. So when you go to the higher power, you will see these small cells, very tiny cells, blue color cells. You can write them as small blue cells, scant cytoplasm. But what you see in the background is known as amyloid. Here there will be amyloid deposit. So this is one more terminology which you have to remember. Calcitonin was first term. Second term was about the infiltration, the variety of the gross, and third term is amyloid. Three things you have to remember in medullary carcinoma of thyroid. Apart from that, you write the genetic mutation, RET-PTC gene, okay, and you write about the Men's syndrome, that it is associated with Men's syndrome, one line. That's all. So this carcinoma has the maximum points to write. Unlike follicular and PTC, you can just make up your story. Here you can't make up, you have to remember them. Fine. So these are all the malignancies. You have to know 3 of them, and these are all the causes of hyperthyroidism. So when you are asked the differential diagnosis of thyroid swellings or hyperthyroidism, both ways your malignancies should not be ignored. Apart from that, you are writing about Graves' disease in one thing. You are writing about the simple goiter, the multinodular goiter. These are all your thyroid swelling will complete the entire diagnosis. Fine. Now we are moving on to hypothyroidism. It's a small topic. Oh, this is not required. It's okay. We have time. You came late. Fine. So hypothyroidism. Just pay attention because this is a bit confusing with the Graves' disease. Last bit of it, and one is big, one is small. You will be done in another 10 minutes. So hypothyroidism is, as I was telling you, that T3, T4 levels will be. Oh, the backbenchers are listening. The front one are sleeping. Okay. Too much sleepy. Okay. Low or high? They are telling low. Low. You are also low. Everybody sleeping. Fine. Okay. Yes, it will be low. Okay. Your all basal metabolic rate has gone down post lunch. You are eating like canteen food, home food, Swiggy food, mess food. Mess food के बाद नींद नहीं आनी चाहिए. Mess food is best. What did they give? It's mess. Okay. Agreed. This is an age-old problem, you know. Like since when we were studying, we had this issue. Now you are studying, you have this issue. Your juniors will also have it. Nobody ever has got a good food during MBBS. Don't worry. Okay, fine. Come back here. Keep your BMR low because we are in hypothyroidism. Fine. So T3, T4 levels will be low. That is the definition for hypothyroidism. TSH will be raised. Again, the negative feedback effect. Fine. And they are classified into 2 types: primary and secondary. The classification is usually not asked. If you want to remember, well enough, I'll just tell you here. These are the differential diagnosis for hypothyroidism. There are many. I've just listed the most common ones. So primary and secondary. Secondary obviously for different other causes than the thyroid. So secondary causes can be numerous, like anemia, goiter, choriocarcinoma, anything. You can just fill up the list with lot of things. What you have to remember is the primary one. Primary has 3-4 important topics. One is known as cretinism. I'm sure you must have learnt it in science and on 11th, 12th. Before that, cretinism is a stunted growth child. Okay, cretinism. So that is one cause which is in the primary. The second one is here, autoimmune. Okay, autoimmune, the name I'll be telling you, that is Hashimoto's. You all must be already knowing it. And one more name comes is mixed edema. Mixed edema, that is more of clinical, not much of pathological, so that you will read there. So you write these 3 names minimum in the diagnosis of hypothyroidism under primary causes. Secondary, you can fit in as many as you remember, whatever you remember, starting from anemia to sleep disorders, anovulatory cycles, malignancies of ovarian tumors. It's up to you. So just pay attention to this Hashimoto. This is important because it is a bit similar to Graves' disease, as I was already telling you. So this is also an autoimmune disorder. Same happening in the younger age group, can go to the older age group. A bit of difference. Graves' disease is always somehow in the younger one, not like elder. Hashimoto can go to, you can sit. Hashimoto is in the older age group. So in this autoimmune disorder, which cells are they attacking? Let's go to, okay, fine. I'll tell you it in some time. So They are attacking two cells here in the autoimmune disorders. One is the thyroid peroxidase and one is the thyroglobulins. Thyroglobulins? No, nobody knows. Okay, fine. Thyroid peroxidase and thyroglobulins, they are the ones which are attacked here. Fine. So you get, how do you understand this disorder is the patient can come to you at any of the phase. The first phase, the early phase is where the patient is just starting to have the hypothyroidism. So everything will be low, the BMR will be low, the cardiac output will be low, everything will be low. Just remember, everything is down. But if the patient doesn't come here and is untreated, then what happens? The thyroid believes that, okay, my metabolism has been too slow, I'm unable to produce thyroid hormone, so it will just go into a thyroid storm. It will revert itself and it will try to produce as much as possible. So that is known as hashitoxicosis. Again, the word toxic. Toxic always means something like status epilepticus, status asthmaticus. Something where the thyroid has gone crazy and it wants to produce lot more things. Fine. If it is not treated as hypothyroidism, then it goes for hashitoxicosis. Fine. Also, there is one thing that this can be associated with other autoimmune diseases. Unlike Graves is not associated with other autoimmune diseases. Hashimoto's can be associated with other autoimmune diseases like diabetes mellitus, myasthenia gravis. Usually it is myasthenia gravis, which is the coordinated part of it. Okay. So this is again the pathogenesis. If you want to write the entire thing, nobody is stopping you. But what I want in your answer sheets are 2-3 things. First of all, you remember from your immunity molecular mimicry. Okay, the antigen is present on all of your body cells. Some of the antigens will start behaving like a viral cell or a bacterial cell. It tries to mimic a bacteria or a virus cell, and it tells itself that I am an antigen, come and attack me. Why it does, we do not know yet. But your own body cells turn into like an outside cell. It starts to mimic the other cell. So that is what is known as molecular mimicry. So once this is there, then B and T lymphocytes will come down and they will attack. So that's the first point I want you to write. Second point is about the genes. Nowadays any answer is incomplete without genes, so you can write as many as you want. And the third thing which I was telling you, it can be related with other autoimmune diseases like diabetes or myasthenia gravis or whichever. So all of them will together cause what? Lymphocytes will come into the circulation, both B and T lymphocytes, and they will attack, they will infiltrate the thyroid gland, they will destroy everything, and there will be reduction in the production of T3 and T4. Okay, so mechanism is same in case of Graves and in case of Hashimoto's. B and T lymphocytes are coming. Only thing is the antigen is different. Graves is TSH receptor and Hashimoto's is your thyroglobulin and thyroid peroxidase. Thyroid peroxidase is part of that T3 T4 production by iodine. Okay, so with them, these are your clinical parameters. You can just go through them. This is not much important. I'll be coming here. So the gland will be in the initial phase, the gland will be normal. It can be normal if the person is coming. Only clinically you can diagnose. Histopathology usually we don't get. We get like fine needle aspiration max to max. So the gland will be normal or maybe bit enlarged or maybe absolutely normal, like palpable, normally palpable. So when we take an FNAC, we get lot and lot of lymphocytes. It might just appear that it is a lymphoid organ rather than a thyroid. It will be so much of lymphoid follicle proliferation will be there. So you have to just remember that Graves we didn't see this amount of lymphocytes. In Hashimoto's we are seeing lot of lymphoid follicles. We can see germinal centers as well. So lot of lymphocytes. Thyroid follicles, some of them will be left out. There will be colloid in that. So this is what is the histology picture. So here you can see these are lymphocytes and they have this germinal center, like a lymphoid follicle with germinal center, and otherwise only lymphocytes are there, and whatever is left out are the small follicles with colloid. Here the similar picture, lymphoid follicles and very less amount of colloid and follicular cells. Same thing. Okay, so this is what is Hashimoto's and that is what is Graves. Both the pathogenesis are important, you should remember them and it will come as a question. The last one is a small one. This usually comes as a short note. This is D. querulans, again on the name of scientist, also known as granulomatous thyroiditis. Okay. So if you remember the term granulomatous, you know what all to fill in the answer paper. Don't write caseous necrosis here. Apart from that, everything is there. Okay. Don't write caseous necrosis, please. Okay. So this is elderly age group problem, also known as granulomatous. Why it is happening? It is because of viral infection. As clear as that. It's just an infection, most commonly virus. The viral, like the virus has affected your body, entire body. Maybe you have a common cold, cough, COVID, whatever, and again those the thyroid molecules will do the molecular mimicry. So with the viral antigens, even the thyroid cells are destroyed. That is all it is. So T3, T4 are low, thyroid follicles are destroyed. And only okay, one more characteristic is it is a painful condition. The only condition in thyroid which is painful. The person will come to you, I am having a throat pain, or like I am having pain here or something like that. So just remember that you can demarcate it by that thing. Common cold history or some URTI, upper respiratory tract infection with a painful thyroid, you should think about dequervins. Fine? Okay, so this is how they look like. There will be some amount of thyroid follicles if left. There will be multinucleated giant cells. There will be lymphocytes. Don't write epithelioid cells as well here. Okay, it's only multinucleated giant cells, and some amount of calcification can be there. Okay, you can see this. This is almost like Langerhans giant cell. Fine, but don't write that name. Just write multinucleated giant cells to be safe. Okay, and you have to write about lymphocytes in them. Sometimes they can go for fibrosis as well. So this is like all about your thyroid. So in thyroid you have got hyper, you have got hypo. Hyper has your malignancy causes. It has got your goiter, multinodular goiter, Graves' disease, and hypo has the Hashimoto's and dequervins. Okay, dequervins you can forget, but Hashimoto don't forget. Fine, clear? Partially sleepy, partially no. Yes also is not coming out. Before leaving you should be at the highest of your Josh. Chalo, take. We'll just take the attendance. From here you just start telling the roll numbers and you can leave the hall. Okay.